Chapter 35, Geriatric Emergencies. Let's face it, our most common group. Geriatrics are technically anyone over the age of 65. Geriatric patients are special challenges for us to deal with. And their injuries and illnesses are affected by chronic conditions known as comorbidities, polypharmacy, multiple medications, and the physiology of aging. These all play a role in what to deal with. We need to understand and appreciate how their life and what they're dealing with is different than yours. We need to be compassionate, understanding, and patient with these patients. Treat them with respect, as you would with anybody. Make every attempt to avoid ageism. I don't know what that means. Sometimes you just have to point out that they're old, which I think is the opposite of make every attempt to avoid ageism. Speak respectfully, clearly identify yourself, present yourself in a respectable, mature, and professional manner. Always look directly at the patient. Try to be at eye level. Notice it's the same as children. Speak slowly and distinctly. Remember the bell curve of life. We start in diapers, we end in diapers. One person talk to the patient, asking one question at a time. Don't assume they're hard of hearing unless they tell you they're hard of hearing. Give them time to respond. A lot of the elderly just take a little bit longer to process and respond. And listen. Be sure to listen. And explain what you're going to do before you do it. And we should do that with every patient, every time. Predisposed to problems not seen during youth. Hip fractures. Remember, osteoporosis, infection weakens bones. Sedentary behavior will lead to pneumonia and blood clots and a whole bunch of other problems. Here are some common conditions and common causes of death. Moving on. The aging process accompanied by changing in physiologic function. All tissues undergo aging. We have different functional or decreases in functional capacity, which will affect how the patient responds to illness. This is why the flu, nausea, vomiting, diarrhea are such a big problem for the elderly. They don't hold the same amount of fluids. Their body doesn't have the ability to replenish what is lost as easily. So airway musculature becomes weakened. A good example of this is phlegm. So we all sometimes experience some mucus and whatnot building up. Mucinex is a drug that helps expectorate. It helps you get that mucus loosened up so you could cough it out. Some of these patients, a lot of the elderly, their muscles in the airway and the thorax and the neck aren't as strong as they used to be. So they'll be prescribed Mucinex and everything will break up, but they won't have the strength needed to actually cough it out, which could lead to airway obstruction. The alveoli become enlarged. This is often emphysema, where they're bigger and less stretchy. And chemoreceptors slow with age as well. Pneumonia is inflammation and infection of the lung due to pretty much anything. Bacteria, virus, fungus. It gets in there, it causes inflammation and fluid buildup. It's the leading cause of death from infection in Americans older than 65. Immune suppression associated with aging increases the risk of contracting pneumonia. So you get a simple upper airway infection and it will much more often for the geriatric patient become pneumonia. Pulmonary embolism causes a sudden blockage of an artery by a venous clot. Patients will present with shortness of breath and sometimes chest pain. Generally sudden onset, and it goes immediately to bad, and it can kill them. Cardiac output declines. Arteriosclerosis contributes to systolic hypertension. Let's think. What's arteriosclerosis? Atherosclerosis. You put an F in front of it, it becomes fat, right? So that is the one caused by plaque and buildup inside the veins and arteries. Arteriosclerosis is the hardening of the arteries. So that is generally, there might not be anything in it, but as the person exerts themselves, those vessels cannot get bigger to increase the blood flow through the body, but the heart's still working harder, which causes an increase in hypertension. So they're at higher risk for atherosclerosis, which is the accumulation of gunk in the pipes. Formation of an aneurysm. We know aneurysms are bad. Again, things aren't as stretchy as they used to be. You're now suffering higher levels of pressure, and the walls can't stretch to deal with it, or they're just weaker. They can't hold that pressure back. The vessels and heart valves become stiff. They begin to break down. Electrical conduction system weakens and lessens, and it leads to abnormal heart rates, abnormal heart rhythms, and the veins stop working correctly. The little valves in the veins stop functioning properly, and then eventually it could lead to DVT, and that DVT, that clot, travels through their body, lodges in the lungs, and then you have your pulmonary embolism. You block blood flow to the lungs, then oxygen cannot get to the body, and you have problems. I don't know what's going on here. Sorry, I'm trying to multitask. Oh no, I don't do that well. Heart attack. Classic symptoms are often not present in the older human. Look for signs and symptoms of chronic cardiovascular disease. Heart failure will differ with right or left-sided failure. Right-sided failure occurs when the fluid backs up into the body. Left-sided failure happens when fluid backs up into the lungs. Pulmonary edema, shortness of breath, congestive heart failure, CHF is a big problem that a lot of patients live with for a very long time. Paroxysmal nocturnal dyspnea, a sudden attack of respiratory distress while patients are sleeping. This is generally why your CHF patient does not lay flat for sleeping. A lot of CHF patients are going to be found sleeping in a lazy boy recliner. They could recline, but they cannot lay flat. Supine position is very bad for the CHF. Stroke, leading cause of death in older people. You notice a lot of these things, leading this, leading that, whatever. Preventable risk factors are smoking, diabetes, hypertension, obesity, lack of exercise. So reading that list, I'm destined for stroke. Uncontrollable factors: age, race, gender, family history, and signs and symptoms. Hemorrhagic strokes are less common and more likely to be fatal. That hemorrhage, right? Bleeding. Broken blood vessel causes bleeding into the brain. Ischemic stroke, when there's a blood clot, that's what we see more often. This is where our TPA, clot-busting drugs, could fix the problem. If you break up that clot, blood starts to flow again, and everything's fine. You have a few hours. This is why knowing when the stroke started is so important. TIAs, transient ischemic attacks, generally it's a small stroke that corrects itself. So they have sudden onset of stroke-like symptoms, and then they resolve, generally prior to the ambulance getting there. Sometimes they'll resolve during your long-ass transports from the sticks to the hospital. But that is generally the difference. The TIA is short and resolves on its own. Changes in thinking, changes in memory. Oftentimes things don't work that way. Brain decreases in weight. Performance of most of the sense organs declines. Oh, this isn't related to stroke. I'm sorry. I need to stop trying to multitask. We all know it doesn't work for me. So the nervous system breaks down. It weakens. Brain decreases in weight. It's actually shrinking. Performance of most of the sense organs declines. This is why, like the sensory organs and the tongue, they're not as sensitive. So my grandma, we'd go to Friendly's once a week when I was an itty bitty kitty, and I'll never forget, the soup would come out. She'd always get soup, and it was never hot enough. And over time, we found that they knew it was her, and they would put it in the microwave until it was boiling and rush right out, so it was still bubbling in the cup. And if she saw the bubbles, she knew it was hot enough, which just blew my mind. It stuck with me all this time because that was ridiculous. Who could drink boiling soup? Yeah, somebody 70 or older whose tongue just doesn't work anymore. So that's one example of declination of sensory organs. Vision, decreased visual acuity, depth perception, ability to accommodate light. So their pupils won't get small enough on bright sunny days. They have to have sunglasses or they're blinded by the light. Visual acuity, depth perception, this is what causes them issues for driving. This is why even though you think, they're like 90,000 years old, they're close to death, you'd think they'd want to get where they're going before they die, but they're going like 30 miles an hour on a highway. It's because they can't tell how far away that car in front of them actually is. Inability to see up close. Glaucoma, macular degeneration, retinal detachment. These are all things that hit the elderly. Man, I wish we were actually in class so I can make fun of some of you and ask you about your experiences with these things. But no, we can't do it right now. Hearing. What? High frequency sounds becomes difficult. For the most part, your hearing impaired will have a lot more difficult time dealing with a female voice than a man's. When somebody with a nice deep baritone voice comes in and speaks loud and clear, they tend to be able to understand them better than your female partner. Balance issues. I mean, this is why they should have walker. Other than weakness, canes and walkers are there because their equilibrium's off. Their balance sucks. Asbestosis? Sure, it's that thing listed there on the third dash. Hereditary. Long-term exposure to loud noises is obviously an issue. Our World War II vets are rapidly declining. Big issue with them because they spent years fighting wars without any hearing protection. Our Korean vets, some of them are still around, they have the same issue. And by Vietnam, our soldiers were wearing earplugs. So they have a lot less hearing loss. Unless they were in the artillery, those guys are all deaf. Machine shops, construction, back in the day, which was a Thursday, they did not use hearing protection like we do in the last 10, 15 years. So, retired people tend to have a lot of hearing loss, and most of it's because of occupational hazards more than anything else. For us, it's going to be loud music. Once we're old and decrepit, the level of sound that we subject ourselves to in our leisure time now far surpasses anything our now elderly ever considered doing. All their loud noises were occupational. Taste, there we go. Think of my grandma. She didn't like me. Touch, sense of touch and pain perception decrease, sensation of hot and cold decrease. They may be injured and not know it. This is something you need to watch out for the fall down go boom calls. There's a good chance that they hurt something. If they hurt something and they tell you it hurts, it probably really hurts. Then there's a patient who hurts all the time for whatever chronic pain issues they have. Dementia. This is a difficult condition to deal with. Dementia presents in all different ways. Sometimes it could be combative and angry. Sometimes these people could be a Dr. Jekyll, Mr. Hyde, where sometimes they're sweet as can be, and then one thing could set them off and turn them absolutely pure evil. Some are pleasantly demented, some are absolutely miserable and sad all the time. It's just very difficult. They might forget that they cannot walk. A lot of your falls in the dementia wing are exactly that. It's the middle of the night, they want to go to the bathroom, they forget that they're too weak to walk, they try to stand up and they fall down, go boom. Oh, it might be a short-term memory thing, it might be a long-term memory thing. A lot of these patients remember 30 years ago vividly, and they can't remember what happened 5 minutes ago. It all depends on what part of their brain is deteriorating. They might not be able to perform daily routines. Sometimes they're getting along just fine on their own, and this gradual downward slide hits its point where they're no longer able to sustain living on their own. And this is generally where we get called in. And the wheels of healthcare turn slowly. So there might be a few weeks there while they do not have the appropriate support services in place, where you're going to get called there a lot for a lot of different reasons. And it's all based on the patient not being able to care for themselves. Decreased ability to communicate, decreased ability to make sense, decreased ability to take their medication when they're supposed to. They may appear confused or angry. They might be confused and angry. They might make bad choices. So it's sort of like that bell curve of life again, and not be able to vocalize their pain or clearly explain what is hurting. Delirium. Yeah, delirium. This isn't something you're going to see too often, but it's a sudden change in mental status, consciousness, or cognitive processes. The inability to focus, think logically, and maintain attention. 15 to 50% of hospitalized people aged 70 years or older will suffer some sort of delirium. Generally, reversible physical ailments or metabolic causes will cause it. Assess and manage the patient as appropriate for the situation you're presented. One of the most common times to see delirium in the aged is due to a urinary tract infection. I'm sure some doctor somewhere could explain to you why. I don't know why. I just know that it's true, and it could be really awesome to see. They will lose the ability to stand and walk like normal. They will lose the ability to think, and they will present as absolutely out of their mind, delirious. Syncope? Yeah, I'm joking. It's syncope. Syncope is actually passing out, losing consciousness for a moment or three. Considered a life-threatening problem until you could prove otherwise. Would often caused by an interruption of blood flow to the brain. Often the cause will be unknown and undiscovered. You could look at your little chart here. Disorder of the nerves of the peripheral nervous system, function and structure are impaired, called neuropathy. Generally caused by diabetes. Diabetic neuropathy is very common. Often affects the feet more than the upper extremities. So these people cannot feel their feet. They're assuming they're under them. They walk slowly, carefully, and there's a good chance they will trip and fall down. Rugs are the enemy to somebody with neuropathy. And this is something where, we could possibly help people. We go for a fall and we see that they have little throw rugs all over the house and they tell you that they have neuropathy. Recommend to them getting rid of the rugs. Rugs get bunched up and they trip on them. Recommend they get rid of the cats. Cats get bunched up and they trip on them. That's not entirely true. I just don't like cats. Symptoms depend on which nerves are affected and where they are located. Sarah's going to get or to feed the horses early, so I will have her get an application for you then. Maybe you could swing by. Bring a shovel. Changes in the GI system, reduction in the volume of saliva, dental loss, gastric secretions are reduced, motility slows, decreases in bowel movement, impaired liver function. This all, yeah. So decrease in bowel, motility slows. We could expect constipation to become an actual blockage a lot more often. Reduction in saliva can cause issues with swallowing and choking. The gastric secretions, they're not going to produce as much stomach acid. They're not going to digest their food as well. They're not going to get nearly as much trace minerals out of it. GI bleeding, a lot more common and deadly. There's a unique smell to it. Once you smell it, you will know it. Diverticulitis is very common. Look it up. It's awful. Bleeding in the upper and lower GI. Bleeding in the upper GI system, peptic ulcers. We can assume that if they're vomiting coffee ground substance, their bleeding is upper GI. If they're pooping out black tarry stool, it's lower GI. Sometimes the upper GI can work its way all the way through the system, but remember, the stomach doesn't like blood in it. So if something in the stomach or above is leaking, then they're most likely going to vomit. Bowel obstructions, again, they're a big issue. We could generally tell if something's truly obstructed by putting our stethoscope on their abdomen and listening for borborygmi or bowel sounds. GI system, ask patients about NSAID use and alcohol use. Orthostatic vital signs could help determine if a patient is hypovolemic, meaning not enough blood volume, not enough fluids in their system. Orthostatic means to take their blood pressure supine, lying flat, sitting up, and standing. and doing it over the course of about a minute, minute and a half. So you do one, you give them a few seconds, stand them up, do it again, give them a few seconds, stand them up, do it again. It should be in your book describing the process clearly. Nasogastrointestinal complaints. The acute abdomen. Difficult to assess. Most serious threat from abdominal complaints is blood loss. Aortic aneurysm is the same thing. Rapidly fatal condition. They're fine, they're dead. Renal systems, reduced renal function. They're not processing as much toxins out of their system. They're not going to have as much urine output. What else? Decreased bladder capacity. I already suffer that. Sphincter muscle control. Decline in voiding senses, so they don't know that they need to go to the bathroom. Nocturnal voiding, yeah. So we go to sleep, we wake up. Go to sleep, we wake up, we go to the bathroom. That happens more and more as you age. And then your BPH, where your prostate's not working quite right, but it's not cancerous either, benign. Incontinence is a normal part of aging. That's what ending in diapers means. Skin irritation, breakdown, urinary tract infections, all very common. And often the UTI is why you actually get called. The skin breakdown and irritation is why they scream when you try to move them. Urinary retention is the opposite of incontinence. It's where they cannot void. Renal failure may be caused by it. Reduction in thyroid, which could screw with their whole body. Slower heart rate, fatigue, they're always tired, dry skin, brittle hair. They can't handle cold, they get fatter. A lot of this has to do with the thyroid hormones. And then there's the HHNS, complication of diabetes, which we went over when we talked about diabetes. Signs and symptoms, infections are seen in older people because of their increased risk, less able to fight those infections. They appear to have anorexia, be very, very thin and just sickly looking. They're tired, they lose weight, their mental status is decreasing. They get pneumonias, UTIs, especially if they're bedridden. They don't get out, they don't move around, so that fluid just pools there. The heart's not increasing at all to really move it around. And signs and symptoms may be decreased or minimized. So they might have something major going on and there aren't major signs or symptoms of it. The musculoskeletal system breaks down. Bones break more easily. They're very brittle. They lose their density. Calcium sort of fleets away from their bones. They're weaker. They're slower. Ligaments and cartilage is all breaking down and getting less stretchy. Structures are atrophying. Osteoporosis is that decrease in bone mass I mentioned earlier. The bones aren't as strong. They can't handle as much force against them. Osteoarthritis is the joints breaking down. Formation of bone spurs in the joints, which causes lots of pain and joint stiffness. The stiffness leads to a lack of mobility that leads to the patient just not wanting to get up. And then because they don't get up, they get weaker and they just keep spiraling down. So the proteins that make the skin pliable are declining. Layers of fat under the skin is thinner, so they have less blood flow to heat them up. They have less fat layer to keep the heat in. The skin's no longer elasticy, stretchy. So bruising becomes more common, skin tears more easily, and skin tears are a big issue. They can be very difficult to deal with. And it appears I have to go to work. I'll get back to this later.
General 6 party 49 Charlie, priority 1.
False alarm at Sarah's call. So, sweat glands do not respond as readily to heat. They're more apt to overheat when it is really hot. And that could be a problem, right? Hyperthermia can kill. Pressure ulcers. The pressure from the weight of the body cuts off the blood flow to the area of skin. This happens to patients who stay in the same position too long. It's very common in the bedridden. Pad voids and under bony prominences. That's more of an unrelated. So really you should do that anytime you move the patient. If they have any deformities, weird curvatures, you should definitely pad those voids. And any place where the bones are like jutting out and is really going to press extra pressure on the skin, you should add some sort of extra padding to that area. So more susceptible to toxicity because their kidneys can't filter out the toxins. Their liver isn't working so well, or as well as it used to. It can't filter out toxins. And your GI absorption rates are altered, generally decreased. Decreased liver function makes it harder to detoxify the blood and eliminate medications and alcohol. This is a big thing for Coumadin. Remember, patients taking Coumadin, the blood thinner, they have to have their Coumadin levels measured on a regular basis. And a lot of that's based on the fact that the liver declines. And as it declines, even though they're taking the same dose, it's staying in their system longer, and it's going to build up more and more and more until they develop uncontrollable bleeding. Alcohol will do the same thing. The long-term alcoholic who's getting older and the liver is getting worse and worse at doing its job, that alcohol, they're going to be able to drink less and less and stay shit-faced for longer. And eventually they could come to the point where drinking the same amount as they always have will become acutely deadly. So, yeah, this is interesting. Over-the-counter meds have a negative effect when mixed with each other or with herbal substances, alcohol, and prescriptions. So drug interactions is something that patients really need to be aware of. Ooh, excuse me. So polypharmacy, this is something that you should expect to see a test question or two about. Use of multiple prescription medications by one patient. Negative effects can include overdosing and negative medication interactions. This we see a lot when it's getting better with the doctors having, being allowed to share information with each other when the patient signs those silly little forms. But if the doctors pay attention, then you shouldn't have as much polypharmacy. But a lot of times you'll have, a specialist for your arthritis giving medication, and a specialist for your heart giving medication, and your your primary care physician giving medication for stuff. And sometimes they don't communicate with each other, or the patient goes to the doctors and forgets to properly document what the other doctor is giving them, and then they end up getting prescribed medications by multiple doctors that don't work well with each other. Or in some cases, two doctors will prescribe the same med, and the patient will take both prescriptions and overdose. Med non-compliance is the opposite. That's when they're not taking their pills. because they can't afford them, because they just can't open the container, or because they can't remember to take them or remember how to take them correctly. Depression is not part of normal aging, but is considered a medical disease. It's treatable with medication and therapy. If it's left untreated, it is associated with higher suicide rate than in any other age group. Older men have the highest suicide rates. They tend to choose much more definitive means, if you will, than younger victims. Most older men tend to use a bullet. Common predisposing events and conditions. So ultimately, they find out they have cancer, they give up. They have a chronic condition that's worsening, they give up. They lose their spouse, they give up. If your patient is showing signs of depression, it is appropriate to ask if they have a plan. The GEMS diamond, I have absolutely no idea what this is. But it's to help you remember what is different about older people. Oh, wonderful. Sure. I don't. Yep, moving on. Assessing. Special considerations. Communication. Hearing and vision deficits. So often the family will take out the patient's hearing aids once you show up. So you get there, you say hello, they respond, everything's great. And then the daughter comes in and takes out that hearing aid because the hospital lost it on their mother 25 years ago before she died, and we're not going to go through that again. So now you're stuck with a patient who can't hear a goddamn thing you're saying. So yeah, really try to get them to leave the hearing aids in, at least for your ambulance trip. Can they see? If they can't see, you need to really communicate using your voice. You need to make sure that you explain everything that's happening. Alterations in consciousness, they might not be quite with it at their baseline, so that's normal for them. It's not the sign of an acute medical condition. They're just always kind of loony. Complicated medical histories, multiple surgeries, multiple organ problems, heart problems, lung problems, and the effects of the medications. All things that are going to make it harder to assess your patient. Commonly found in their homes, retirement homes, SNFs, skilled nursing facilities. A lot of old people live alone. A lot of old people don't want to live anywhere else. And we tend to get called as they are losing their ability to be independent. Access may be hampered if their condition prevents them from getting to the door. We need to be advocates for these people. If we finally get in the first time, we need to really stress to them how important it is to have a hide-a-key, a lockbox, a door code, some way for us to get in when they're incapacitated. Take note if their house is negative or unsafe. Are they hoarding? Is it just unkempt? Do they have so much furniture that you can't get in and out? You need to point this stuff out. Hopefully you could talk to a family member, their children or whatnot, to get the situation corrected. We need to be aware of the mechanism of injury, the nature of illness. It might be difficult to determine if there's mental status issues or dementia. Ask family member, caregivers, bystanders why they called. Because generally these patients, when they're really altered or demented, they are not calling themselves. Somebody else is calling the ambulance for them. Be aware of multiple and chronic diseases and how they complicate your determination of injury or mechanism. I can't get out of this anti-gravity chair. I think it's an extra gravity chair. I wish I could turn the camera on and off so you could see the things I'm talking about. But I figured out how to turn it off, and I'm afraid of what might happen if I ever turn it on again, so it's staying off. Address life threats. Obviously, it doesn't matter how old somebody is. Address the life threats as you find them. Determine transport priority. Transport them appropriately. If they're circling, transport them quickly. Don't waste time. If they're not circling, then take your time. Old people don't like to be rushed. If it's not absolutely critical that you rush, then don't rush them. Take your time with them. AVPU to determine their level of consciousness just like any other age group. That's not dependent on age. Airway and breathing. Make sure they're breathing. Make sure their airway's open. Make sure that they're not obstructed by dentures, vomitus, fluid, blood, or food. Anatomic changes affect a person's ability to breathe. Just their body's shrinking. It's getting stiffer. Loss of mechanisms that protect the upper airway cause a decreased ability to clear secretions. Remember I mentioned that about Mucinex like 50 slides ago? I mean, it's a thing. All those muscular actions are decreased. They don't work like they used to. They might not work at all. And it might make it harder for them, they vomit a little bit or a lot of it, and then where we give that final cough to really clear it all out and hawk up the last little bit of it, they're not able to do that. Circulation, poor peripheral perfusion, the 3 P's of aging. It's a serious issue. The blood just doesn't flow like it should. Lower heart rates, irregular rhythms are very common. Your AFibs are very common in the geriatric patient. Their whole heart rate's slow. So, my wife might have a resting heart rate of like 50 because she's extremely athletic. I think it's gone up a little bit since, she's getting older. Shh, don't tell her I said it. But since she had the children, all 3 of those little monsters, it has gone up some. I think she's now in like the 60s, 70s. But chances are when she's 80 or 90 and I'm long dead, it will probably be back down into the 60s or 50s. That might not be enough. These patients suffer syncope because of it. And, circulatory compromise, the poor peripheral perfusion, it might be very hard to feel a pulse, a peripheral pulse. You might really have to press hard and exert some pressure and give it some time to get that radial pulse. Complaints that compromise the ABCs should result in prompt transport. Determine conditions that are life-threatening and give prompt transport. Treat them to the best of your ability. Treat for shock. Call for ALS if necessary. And provide transport to priority patients. I mean, that's such a silly thing to even put in a slide. Older patients will easily decompensate. So here we go, bell curve of life again. So many things that our pediatric patients face, our elderly do as well. Investigate the chief complaint. Medications are very important. Try to get a look at their medications. So often all they have is that little pill dispenser, for the days of the week, morning and night. Try to actually find the basket of medication bottles. Look around, see if they have a bunch of full medication bottles, 6 or 7 or even 2 or 3 of the same medication. Try to investigate that. Try to point that out to the hospital. Every emergency department should have a medication reconciliation agent, someone that's just there to look at their medications, make sure they're taking them correctly, and make sure that there aren't going to be any drug interactions. Determine early whether their altered level of consciousness is new and sudden or been there a long time, acute or chronic. You might have to rely on a relative or caregiver to help you. Generally, that's fine. They have people that love them and have known them at least all of the relatives' lives. And they know their history. They know their medications. They know what's going on. So it's all right to have to rely on them. It's great to be able to get information from your patient, but sometimes you can't. And oftentimes that's okay. We want to definitely list their medications or take them with you to the hospital. That is your distant second choice. We definitely want a list of medications. Try not to take their medications to the hospital. The chance of them getting lost, stolen, are very possible. And remember, the hospital has a full pharmacy at its disposal. There shouldn't be anything they're taking at home that they cannot get at the hospital. If they're on some crazy med for some crazy disease, and the family or patient says, I have to take this with me, then by all means, take it with them. But don't take the shopping bag full of pill bottles with you. Don't do it. Take the extra time to write them down. Even better, find the list already written, and if they don't have a list already written, try to encourage that patient to create one and put it on the refrigerator. And transport to a facility that knows the patient's medical history. I mean, in our smaller towns with very few hospital choices, that's quite possible. If they tend to do most of their care at a hospital far away for whatever reason, you might not be able to take them there. It's really hard in an emergent situation to bypass a hospital to go to another one unless you have a very good reason why. And my doctors are there is not a very good reason why. Because guess what? There's doctors at the closer hospital too. Older patients may not be comfortable with being exposed. Just tell them it's all right. I'm not bashful. Generally, it'll get enough of a laugh to get the job done. I love that line. Protect their modesty to the best of your ability. Explain what you're doing. Ask for their consent. And try to keep them warm through the whole thing. I mean, anytime in the winter, I did one call with a volunteer whose abilities I don't have the greatest amount of faith in, and who, in general, just really drives me effing crazy. She drives me nuts. I hate dealing with her. But anyways, we get to a call. I happen to go right to the scene in my POV, personally owned vehicle, and we arrived at the same time. She hopped out of the ambulance, went in the side door of the back, left it open, grabbed the first in bag, climbed out the back door, left it open, and went inside. We already had a first responder inside who was doing a great job, gave us updates. We knew the patient was stable. And I came in and shut the doors and turned on the heat. Now, mind you, our heater has a control in the front that's very easy to hit one button and turn it on when you're in the driver's seat going to the call. Did I mention that night it was 4 degrees outside with a 12 to 20 mile an hour wind? Did I mention that? Yeah. This patient was 92 years old and suffering, I believe, a urinary tract infection or pneumonia, something like that. It was probably pneumonia. And their house was ground level. Her first inclination was to go in and do a full first initial assessment, even though we had a first responder that already did it. Oh, I get a headache just thinking about it. I think this one's my call. And but in the end, walk in, first floor house, and I managed to shut the doors, bring the stretcher inside, keep her warm the whole time, get her all bundled up before we went outside, and I'll get back to this in a few minutes.
Car 5.
5, go ahead. I gotta plug this in.
5, 422 Riverside Ave, 422 Riverside Ave. Cold cleared in for the site, 1918.
All right, where'd we leave off? It's been several calls and several bleachings later. Older patient might not. Oh yeah, modesty for them, not for us. And absolutely, we need to keep old people warm. They, like little children, do not like to be cold, and they get cold easily. Heart rate may be lowered due to medications. We call these medications beta blockers. So even if there's a situation where the body really needs the heart to speed up, it's not going to because there's medication stopping it. Weaker, irregular pulses are common. They're probably the patient's baseline. Circulatory compromise make it difficult. We call it, covered that. Other points might be, you might have to go to the carotid brachials might work. Reaching for a femoral pulse on a geriatric patient is probably not in your best interest. Refer to that whole modesty thing. Blood pressures tend to be higher. They tend to be regulated by medication as well. Cap refill's useless. Respiratory rate should be in the normal adult range. You should auscultate, listen to their breath sounds, and assess pulse oximetry and carefully assess, meaning be aware of erroneous readings due to cold fingers and poor peripheral vasculature. So if they have really cold hands and no blood flow going to the hand, you're probably going to get a really low reading. It doesn't mean that they actually have low oxygen saturations. It means that you need to further investigate. Do they have a saturation of 78 and they're extremely confused, cold and clammy, and showing signs of shock? Well, then it's probably accurate and you need to do something about it. But if they're completely alert and oriented, and talking to you, breathing normally, good depth and rate, then it's probably just a bad reading. So you need to be aware of that. Treat your patient, not the machine. Reassess often, recheck your interventions, maintain position of comfort, assist ventilation as necessary, provide psychological support. Let's call that reassurance. Provide constant reassurance. Document their history, medications, your assessment findings, and any interventions you provide. This chart's interesting. It gives you some good insights. For sure, take a look at it. Certainly not something that's really going to help you with testing purposes, but it does give you some good ideas on what to look for when checking out an old person. Oh yeah, remember, you're not supposed to call them old. Normal changes create risk and complicate your assessments. Slower homeostatic compensatory mechanisms. What does that mean? It simply means that their body systems are not going to react to changes quickly. If they have sudden exertion and need their heart rate to speed up and their breathing to speed up, it's probably going to lag behind what the body actually needs. They don't have reserves. They don't have much glucose reserved in their liver. If they do, their body's not any good at accessing it. They don't have fat stores that their body can actually access. And existing medical issues is another one that's going to complicate your assessments. Remember, you're there for an acute situation, hopefully. It is a 911 call, and whatever their ongoing conditions, their chronic conditions are probably going to complicate the situation. Physical findings are harder to find. That's our top dot. The healing process does take longer. What might take me a few days to heal a little cut or abrasion might take them a week or two. Sometimes they might end up having to go to a wound care specialist because it's not healing at all. Old people that get hit by a car, it's absolutely a problem. Remember, these people are not bendy. Whatever is contacted and is subject to those extreme forces is going to break. The linings on the organs are not very pliable. If anything hits them hard, they're probably going to rupture. So pedestrian struck when they're over the age of really 50. Anything really middle-aged adult is where these issues start to become more prevalent. And for sure, somebody in their 70s or 80s gets hit by a car, even at low speeds, you need to consider that a significant mechanism. Higher risk of burns, they're not moving as quickly. If they do sense the heat, it's going to take them longer to get away from it. Risk of mortality is increased when, they wake up in the morning. Um, Pretty much anything that goes wrong is going to increase their chance of dying. Pre-existing medical conditions, absolutely. They have something medically wrong with them. It's leading to their demise, maybe slowly, but if you compound it with something acute, it's most likely going to speed up that issue. Fluid replacement is complicated by renal compromise. This really is not an issue for us at the basic level. We're not doing fluid interventions. We're not even letting them drink liquids. So this isn't really a big concern for us, but it is something we need to be aware of as far as treating a patient with renal failure. Higher mortality for penetrating trauma, absolutely. I mean, internal bleeding, it's harder to get them to clot, especially if they're on thinners. Falls for the geriatric patient is a big deal, especially if they hit their head and sustain a bleed or swelling. A hip fracture for an 83-year-old female could be a death sentence. So we need to treat these patients aggressively and get them to the appropriate facilities. Anatomic changes. So the big ones, we're sort of driving this point home that overall physical condition or lack of good physical condition will lessen the body's ability to compensate for simple injuries. So what to us seems like a minor situation could actually be very serious for the geriatric patient. Yeah, osteoporosis means a greater incidence of fractures, compression fractures, spinal fractures, walking down the stairs and taking a step and fracturing their hip. It's just osteoporosis. Their bones are decaying, more or less. Brain tissue smaller, which increases the risk for closed head injuries. So there's more room for that brain to bounce around, and there's a better chance of it smacking the skull and having acute subdural hematomas, and they are deadly. Often missed because the mechanism may seem minor. They fell from standing. Their negative symptoms and signs may also take longer to produce themselves. So you get there 10, 15 minutes after the fall, and they're still alert, conscious, oriented. They have a slight headache, and that's about it. They're not on blood thinners, and you think it's all right. They're going to be all right. You let them refuse, and by morning, it's not all right. So we need to have a higher index of suspicion for a simple fall with a head contact in the fall to become a serious issue. Internal temperature regulation is slowed, so their body gets really cold before the body starts to try to do anything about it. It gets really hot and the body takes too long to try to do something about it, and then it cannot cool itself down effectively or enough. Hyperthermia doubled in the geriatric population compared to middle adults and younger humans. Half of the hypothermic deaths are older people. I mean, temperature really does matter. We laugh when they say that they're cold, and how often do you hear somebody 82 years old say they're hot? Very rare. So this is the chicken or the egg topic. Did they fall because they died, or did they die because they fell? You need to look for clues that'll give you the answer to that question. That's the extreme. Are they acting like they had a stroke because they fell and hit their head, or did they have a stroke which caused them to fall? That's another example. Obviously, address life threats. Always, every call, every patient, no matter the age or the situation, address life threats first. Find them, take care of them, and then move on. Determine transport priority soon. Older trauma patients be transported to a trauma center. I mean, ultimately, all our trauma patients should go to an appropriate facility. General oppression using your AVPU, your GCS. Patients talking, the airway's good. Patients with noisy respirations have a compromised airway. Diminished ability to cough. I've mentioned this a few times. I told the story at the beginning of this about an hour ago. So that's something to be aware of. Assess for presence of dentures. Are the dentures loose? Are they obstructing the airway? Circulation, drinking alcohol, and anticoagulant medications can make bleeding control difficult. That's and or. So alcohol without anticoagulants will still make bleeding control more difficult. The two together are going to wreak havoc. They'll easily go into shock. You need to sense it early and treat it aggressively. So a patient that's this last dash are normally hypertensive. They have a high blood pressure all the time. They are going into shock and you get their blood pressure and it seems normal. Well, is it normal for them? That's what's important. What's their normal blood pressure? Investigate the chief complaint. Considerations in your assessment must include past medical conditions. Even though you're there for an acute situation, we need to factor in how the chronic ailments will affect it, or if the ailments have anything to do with this acute situation. So physical exam is a physical exam. You're going to perform it as you would with any other adult. We need to keep that index of suspicion for more damage from trauma. What might not hurt me so much will destroy them. Head injuries, consider them all life-threatening and treat aggressively. Consider that breathing may be impaired. If they're not conscious, they can't tell you. If they are conscious, generally, even the most demented patient could tell you if they're having trouble breathing. Assess all their vital signs. Cap refill could be ignored. Remember beta blockers. The heart rate might be artificially normal because of medications. You need to know your medications, or their medications. Decompensating after trauma quickly. Broken bones, of course they should be splinted just like anybody else. Do not force a patient with joint flexion or kyphosis into normal position. Splint them how you find them. Unless there's peripheral motor sensation loss, numbness, other signs that a blood vessel is occluded, then you might want to try a little bit, but be very gentle. Try once, and if it doesn't work, just splint it the way you found it. In general, the best bet is to splint it as you found it. Hip and pelvic fractures, try not to log roll. Sometimes you have no choice. If you do have to log roll, try to log roll onto the side that seems less injured. If you log roll with a pelvic fracture, there's a good chance you're going to do more damage. The best way to get them moved is with multiple providers lifting them straight up. A lot of times you could sort of shimmy a sheet under them and then use the sheet to lift them up. Sheet lifts are great. Provide blankets and heat to prevent hypothermia. Remember, even on a nice warm day, a geriatric patient could still become hypothermic fairly easily. Psychological support, again, that constant reassurance. Let's talk about falls, baby. In general, our falls are simple mechanical falls. They tripped on a rug, they tripped on the cat, they tripped on their dog. They went to reach for the wall and missed. They tried to take that little step from, the threshold from one room to another at a lower level, and it didn't quite work out. They got out of bed and just sort of slipped. They're wearing socks or crappy slippers, and they slipped on the hardwood floor. All kinds of things are just mechanical. But then sometimes it's because, there's something going on with their heart and they suddenly got weak, and it was more of a syncopal episode than a simple fall. Medication interaction as well. Medication, some of them, especially when combined with others, can make them dizzy or weak or lightheaded, all of which can end in a fall. So you need to find out why they fell. If they remember the whole thing, they weren't dizzy or lightheaded, they could explain to you exactly how they tripped on the carpet or the rug, the throw rug that they shouldn't even have, or they tripped on that stupid slipper that they shouldn't even have. If they can't explain those things to you, then you should probably consider it to be a medical cause, and that is of concern. Nursing homes, skilled facilities, in general, they're awful. We hate to go there. There's no telling what you're going to get. Generally, you're going to get providers that really don't know how to provide. And most of those patients are at baseline altered. And again, when you get called for somebody who's altered at baseline and you get called for altered mental status, it's really hard to deal with. What is wrong with the patient today? Why did you call the ambulance today? That's what we want to know. Nursing and skilled facilities. Infection control needs to be a high priority, especially right now with this SARS-CoV nonsense. We need to be aware that most of the providers at SNFs are not taking constant precautions. Virus spreads like wildflowers. Well, those spread pretty good too, but you know what I mean. So we need to be aware of this stuff. MRSA at this point is the least of our concerns. Vancomycin-resistant enterococci is VRE. It's basically like an even worser staph aureus, a worser MRSA. It's a different bacterium, but it's a bacterium that is supposed to respond to Vanco, and it doesn't. Syncytial virus, C. diff, Clostridium difficile is C. diff. That is a poop disease that's really hard to get rid of, very contagious, very hard to kill. Dying patients. More patients are choosing to die at home rather than a hospital. They tend to receive what we call hospice or palliative care. Keep them comfortable, let them go with some sense of dignity. Be understanding, sensitive, and compassionate. Remember that a do not resuscitate order is not a do not treat order. We could still treat them. They could still go to the hospital. We want to keep them comfortable and treat the acute conditions just like we would for any other patient. There is nothing worse than having your paramedic get on scene and go, oh, it's a DNR, and then infer that they're not going to do anything for this patient because they're a DNR, and that's just wrong. We still care for these people. Now, we might offer a lot more leadway in whether we're going to push for this patient to go to the hospital or not. If there's something acutely wrong that can be fixed in the short term, then absolutely they should go and be managed and made comfortable and then sent on their way. But if it seems to be something that's not going to be fixed in the short term and they really do want to die at home, then it might be a condition where even though you know the condition's going to lead to death, it is okay to get a refusal. Here we go, advanced directives. So advanced directives are for generally the POA, power of attorney, or the named medical decision maker to guide them in what's going to be allowed for this patient's care. DNRs are exactly that. It gives you permission not to attempt resuscitation for a patient who's clinically dead. DNR does not mean do not treat. Hey, I just said that. Basic ABCs should still be provided. Any action on the part of an older person's family member, caregiver, or other person that takes advantage of the older person's person, property, or emotional state is elder abuse. If it involves neglecting them, it's neglect. Basically, leaving them in the bed, taking their Medicare funds, and not actually caring for them would be neglect. Not providing food, warmth, hygiene is neglect. Not caring for their emotional state is also neglect. Do you need your nothing? Just hanging out? Hey guys, I know you can't see him, but my partner's here.
Howdy.
There we go. Yep, he really does exist. Includes acts of commission and acts of omission. So doing things particularly to hurt them is abuse, and not doing things that would help them is neglect. All right, let's do 6 slides of this. So this is kind of an interesting topic. Elder abuse is largely hidden from society, and that's true. A lot of these people are hidden away. They're, in loft apartments in the family home. They don't call for assistance. The victims are often hesitant to report the problem, and this is an issue. Often afraid that the abuser will punish him or her for reporting the abuse. We call that reprisal. That's a real thing. And generally, these people are truly terrified that their situation will get worse if they try to complain about it to somebody outside of the household. Or even if it's a paid caregiver, they might be afraid to tell their family. Occurs most often in women older than 75 years old. That's because old women are giant pains in the butt. No, that has something to do with it. It absolutely does. I took care of my great grandmother with my sister. We sort of, shared the responsibilities for 3 years. And there were times when it was really frustrating and hard not to just smack her around or leave her there. And we didn't. We did a good job until it just got too much, and we're both like, I just want to leave her outside on a cold night, at which point we convinced her that going to a facility where some of her friends were was the best way to go. And it all worked out, and everything was good. We convinced her it was her decision. It definitely was not, but just the same. It happens, and people have the best of intentions a lot of times, and this stuff happens. Also, why do men die before their wives? Because they want to. So you will experience that the women outlast their men quite often. So that will also lead to this statistic. Abusers of older people are sometimes products of child abuse themselves. I don't care. That's no excuse. This may occur in nursing homes, convalescent, and continuing care facilities. Generally, it's more the neglect that happens there. It's not too often that in a home somebody's going out of their way to actually abuse one of the residents. Every once in a while it happens. Somebody could be such a pain in the ass that the providers there, who are barely paid to begin with, just can't handle it anymore, and they want to start torturing them. This does happen, and hopefully it gets caught early. Sometimes the family catches it on those nanny cams and broadcasts it all over the internet, and it makes quite a stir. But it's generally the neglect that you will see in a convalescent home. And a lot of it's not with malice, it's just that they're overworked and understaffed. Suspect abuse when answers are concealed or avoided, just like with the itty-bitty kitties. Remember the bell curve of life. Abuse when you are given unbelievable answers, when the story you're told doesn't jive with the injuries that are presented. Caregiver apathy about the patient's condition. Do they seem to care or not? Are they overly defensive about what you say you see as far as their injuries? The patient's not allowed to answer questions. This also in cases of human trafficking, very common. Repeated visits to the ED or clinic, a history of being accident. Does this sound familiar to a previous lecture? And unbelievable or vague explanations of injuries, which sort of matches with I think it was another slide. But again, these are all signs that you should your ears should twitch if these things are happening. And if you have like all of these, which I have seen, you need to consider it very plausible and report. All right.
I think my ex was supposed to move most of her shit.
It is now 06:14 hours the following day, and I still haven't finished this. So I'm going to sit here for the next 45 minutes till Sarah's off her shift, and we'll see what we can get done. Sometimes I just think they make this crap up. Psychosomatic complaints, yes, that is more than possible and plausible that, they're so anxious and neurotic at this point about being abused or neglected that they artificially inflate their complaints because of it. Chronic pain without medical explanation. Yes and no. I mean, how would you know if they have chronic pain, right? You're there on an acute basis, not a chronic one. So what are we going on? The fact that they just say, I always have pain, therefore we're assuming that is chronic pain? And the fact that they're 90 isn't explanation enough? So I'm not sure how helpful that is. Self-destructive behavior, I guess. Eating and sleep disorders, depression and lack of energy. Yeah, getting abused could absolutely cause you to get depressed. And substance or sexual abuse history. Not necessarily just because they were abused as a child means that they're going to be abused as a geriatric. So I'm certainly not in love with this list. This really doesn't matter. I mean, peruse it, but this chapter's annoying. I'm also retired and aggravated with all the ridiculous PPE I had to wear last night. So bruising in areas like the lower back, the butt, inner thighs, face, and ears, that is useful knowledge. Those are not places that people normally sustain injury and bruising. So this is in line with the children who might have bruising in hard to explain places. The pressure bruises, yeah, it's not too common to see, but they will be fairly noticeable. And human bites, not too many abusers are biting their victims. I suppose it is possible. Human bites look like a human bite. Hygiene's a big one. Lack of reasonable amenities in the home. So do they have the things they need to actually sustain life and some modicum of comfort? If not, it's probably because their caregivers are not willing to provide them. And that's a real thing. It should be noted. This is pretty cut and dry. Injuries to genitals or rectum with no reported trauma as evidence of sexual abuse in any patient. For the most part, yeah. The private areas should be fairly untouched. Oh, wow. So there are 37 Review slides.